Okay. Assalamu alaikum, good evening to the whole crowd. Thank you for joining us for our first in-person event today. So the event we're doing, as the topic says, is healthcare for refugees and asylum seekers. So for those of you who follow us on social media, you'll know that we've had a refugee campaign for the past month or so, where we've kind of covered just an insight into refugees and asylum seekers. We've also covered what is happening in Afghanistan at the moment, because that's very topical. And the structure of this talk today will be three-part talk. So we'll have brief introductions from the society, and then we have our first talk by Dr. Mustafa, and then our second talk by Dr. Aisha, who's currently on her way up, and then our final talk by Dr. Ahmed, who is on Zoom with us, unfortunately, due to last-minute circumstances, was unable to join us in person. And then we'll have an open Q&A. Dr. Mustafa does need to leave after his section of the talk, so we'll have the Q&A after his talk specifically for Dr. Mustafa, and then for the remaining two speakers, we'll have it right at the end, if that's okay. So a brief intro to our society, where we AskDoc UoM Student Society. So who are we? We began in 2019, so right during the peak of COVID, that's when we applied to become a society. We're an extension of the established organisation AskDoc, which has been around since 2011. One of our aims is to create a sustainable presence on a campus. So obviously the AskDoc organisation are comprised of doctors and people from the public health sector, from the finance sector, whereas the student society is comprised currently of just medical students. Our three core aims are to engage, educate and empower. And primarily we focus on community work. I mean, with COVID it has been difficult, but as we continue our work, we want to kind of reach into the communities, actually work with people within the community, not just students. So what have we done so far and what do we have coming up? So obviously due to COVID, the majority of our stuff has been online. So we've had webinars ranging from organ donation, mental health, breast cancer, focusing on all of these topics with a specific focus on the ethnic minority population. We've had a whole host of speakers from doctors, surgeons, community leaders, and patients themselves giving their own personal journey. We're also currently working with the medical school to develop the students' doctors outreach project, which is hopefully going to pilot at the beginning of 2022. And this will kind of give second-year medical students an opportunity to go into the communities, go into the schools and deliver workshops and lectures essentially. So this year, as I mentioned, we've had the cancer campaign and the refugee campaign, where in terms of upcoming campaigns, we've got women's health inequalities coming up and a bit more of a focus on mental health. So stay tuned. So remembering Dr. Ahmed Al-Bayyouk, it would be remiss of me not to have this slide in this PowerPoint, because as the Student Society, so I mentioned, we came about in 2019. Dr. Ahmed Al-Bayyouk was the founding trustee who worked with the core group of students who actually launched the Student Society. And it's kind of the Student Society, the core groups, myself, Rahman, Aisha, we wouldn't have come, the students wouldn't have come together if it wasn't for him to kind of, he was very passionate, very encouraging. He wanted to establish an extension of the AskDoc organisation on campus. And obviously, when we launched and stuff, it was completely during the pandemic, no chance of doing stuff like this, even with masks on in person. So before his passing, we had a lot of conversations about, what is the point of what we're doing? We're not reaching out to those people. And subhanAllah, it was very encouraging, very motivating. Even if you impact one person, even if one person benefits from the work that you guys are doing with the infographics and the information you're putting out there, that is enough. And if he was with us today, he'd be sat on the front row, encouraging and motivating us. But obviously it's been a year since his passing, so please do remember him, his family, his loved ones in your prayers. And I'm going to hand over to our first speaker, so Dr. Mustafa Al-Ackhar. He is a consultant psychiatrist and psychotherapist, born in 2005. He will be discussing with us healthcare for refugees. So,
Where my name is here, but I'm here at least. Ahmed work for now, he's going to get a chance to speak later. So, okay, thank you very much. And thanks, Adnan and friends, for asking me to come and speak here about a topic that is very close to my heart. I'm not a refugee myself. I came from Syria before the revolution and the war started, but like any Syrian, I have been affected massively by what happened, and certainly by hearing the news every day about what refugees and asylum seekers are going through and have been going through. We just heard about 20 of them who have drowned in the English Channel. I think some of you might have heard the news before coming today. So it's a very, very sad situation. I think it's really helpful that AskDoc and other people continue to bring it up and keep it on the agenda again in the public consciousness. So I put Rethink Renewal Society here, which is the organization which works with especially Syrian refugees and refugees in general in Manchester. Look it up, rsoc.org, just put Rethink Renewal Society on Google and it'll come up for you. Our offices are in Longside, and we do a lot of stuff for refugees. One of the things we do is actually something we call Celebrating Syria Festival, and this festival was what brought me to this building 3 years ago. It was my last time here, and we screened a film about home. It was actually a documentary, Syrian documentary about home, and it's really interesting for me to come back here 3 years later to talk about refugees. The defining feature of whom is that they have left home and lost home. You wouldn't be a refugee if you hadn't left home and lost it at the same time. So I thought I would just share that anecdote. At this point, the psychiatrist will probably tell you about the drug companies that have sponsored talks and holidays and all sorts. I've got nothing to declare in this regard, but I need to say, obviously, I've said already I'm Syrian, and I've been affected by what's happened. So I'm not neutral to the question of refugees. I don't come at it from a pure kind of objective perspective. I am a psychotherapist, as you might have seen. For people who are interested in becoming psychiatrists in the future, you can become a psychotherapist from a medical route, and that's what I did become. So being a psychotherapist means I don't really look at people in terms of illness versus health. I look at a continuum, and we're all on this continuum. We're all a bit mad, we're all a bit healthy. So I thought I'd just put that in there as well, just so you know where I'm coming from when I say a few bits later. The final bit is that I don't see things in terms of kind of diagnoses and illnesses. I see that what people present with, which is what we often call mental illness or mental disorder or symptoms of mental illness or disorder, I see those as the result, perhaps, or the manifestation of society that's ill. That's poverty, that's poor education, that's domestic abuse, that's racism, that's discrimination, and all these things. So again, those are kind of my, if you like, starting points where I come from, and just to help you kind of put my talk in this context. So just very basic definitions. We should all be familiar with that now. So this is a refugee, somebody who is owing to well-founded fear of being persecuted for reasons of race, religion, nationality, membership of a particular group or political opinion, is outside of the country of their nationality and is unable to return. So, an asylum seeker is somebody who's applied for protection under the terms of the Geneva Convention and is waiting for a decision to be made by the Home Office. This is UK stuff. Refugee is somebody who's been granted that asylum. Usually they're treated as a UK citizen, and usually they are granted citizenship in 5 years. And the right to reunion with family members. So we're talking about a huge problem here, aren't we? So this is data from June this year. It might not include some of the new data that we have from Afghanistan. But we're talking about 82.4 million people who are forcibly displaced. Now that might include people who are internally displaced, such as, for example, people who stayed in the same country but moved from one place to the other. And we're talking about 26.4 million people. who are refugees right now. Well, that's a huge, that's a few countries put together, isn't it, of refugees. So they come mostly from those countries. I've always dreamt of Syria being in the top of one list or another, as we haven't been, except for this, and that's kind of funny but sad at the same time. So there we go. A lot of them come from Syria, but actually really interesting, 2/3 come from just a few countries in the world. And a large proportion of them also settle in just a few countries in the world. When the Home Office demands or asks some councils to take 12 families here, 5 families there, look at how many Turkey has had to take. Compared to the South, Turkey is probably a bit bigger than the UK. But that's how many refugees they've had to take. Lebanon has had to take about 1.5 million. Lebanon is a very, very small country, the size of Manchester, probably a bit bigger. Anyway, I'm going to keep the political campaigning aside and just keep calm. So, yeah, so a lot of them are children as well. That's really sad, isn't it? 1 million children are born refugees. So without a home, basically. So I'm going to talk a little bit about something again that's really close to my heart and my campaigning in terms of psychiatry and mental health for refugees, which is kind of really criticizing like the common predominant approach that often mental health workers, professionals, researchers, organizations. I'm glad you had MSF in there. I applied to MSF the year after I was in this country, having done my diploma of tropical medicine and hygiene. And I think I was young and naive, so they didn't take me. I was young and naive that I thought they would take me, because they didn't. And I guess I was the wrong person. But anyway, so a lot of charities and organizations working with refugees often take a predominantly medical model, seeing refugees as people with a mental illness, be that PTSD, depression, anxiety, whatever. A lot of organizations, researchers, workers in the field, psychiatrists, psychotherapists, think of refugees as people who are traumatized victims. Therefore, they need help, support, therapy, medication, and so on. A lot of the focus is often on the pre-migration trauma in inverted commas. I'm going to talk a bit about trauma in a minute. So there's that assumption that all we need to think about is what they've been through before they migrated, they took refuge in a new country, because that's where the problem lies. And finally, one of the predominant approaches is thinking about those people in a very individualistic way, as individuals with individual problems. And again, going back to the idea of the psychiatric diagnosis and so on. When they come from very collective, most of those refugees come from the global south, don't they? These cultures are often very collective cultures, unlike the very individualistic. I'm not making any judgments here if any one is better than the other. I'm just saying that our approaches are often individualistic approaches, using what we know works in the UK, in the US, in the West, not necessarily working closely. So you can understand why somebody would think about refugees in terms of mental illness. A lot of them have a lot of mental health problems. A lot of them present having been through multiple trauma or traumatic experiences, and they all suffer from barriers to accessing help for their mental or physical health, either through language, through not even having a stable situation, being moved from one hospital to the other, and so on. Shame and stigma around mental health is still a big thing in this country, never mind in some of those countries where, in Syria, we had hardly had any mental health service back home. How are you going to educate the public about mental health if you don't have a service? So stigma is still a big thing. Refugees go through a lot of problems. The list is much longer than this, but I tried to capture some of them here. I talked about the loss of home, but a lot of other things, the loss of role, the loss of sense of self, the loss of identity, and so on. Realistic fear of future losses, including people who have family left behind, for example, in Syria, in war situations. They don't know whether they will ever see their families again. Violence is very, very common, torture, sexual violence, and so on. The asylum seeking process in the UK, you speak to any asylum seeker, what they've had to go through, they tell you about the horrendous experience, which is often very re-traumatizing. The discrimination, the racism, the hostility from the host community that we often find with refugees, and of course trying to navigate a healthcare system that they have no idea about. Where I come from, we don't have the concept of a GP referring to secondary care, a national health service, and so on. It's very, very fragmented. Often patients come to me and say, do you know of any psychiatrist who I can go to? I say, you have to go to your GP, and they will refer you, and they don't have that, they don't grasp that idea. Of course, poverty, economic hardships, and so on. So, given all that, often what the response we get in mental health services is, let's give you some trauma-focused CBT, some eye movement, and that's going to help you. It's going to help you with all of this. So a lot of them fail. A lot of them get re-traumatized. A lot of them go off the mental health services and system in the UK. Become very disillusioned with the whole of the UK as a place. So we find that effective interventions that we might have here, such as trauma-focused CBT, are very unfamiliar. You start to talk to people about their thoughts, their faulty thoughts, their images, their flashbacks, and so on. Well, they might see their distress in a very, very different way from what CBT, cognitive behavioral therapy, that is, wants them to engage with. The standard treatments that we have will definitely need adapting to the needs, to the cultures, to the language, to the expression that those people have, which is very, very different from what we have. The problem with those approaches I've talked about here, the medical model, the deficit model, the focus on pre-migration trauma, and the individualistic approach, the problem with that is that often refugees' needs are beyond the immediate mental health symptoms that, as a doctor, I often look for and see and document. They often go beyond that into more the social needs that I've been talking about. The majority of refugees do not have symptoms of mental illness. The majority are actually well and healthy. Obviously, if you consider them trying to adapt and trying to survive in a very foreign and strange environment. So only a small minority of them actually you could diagnose. Forget about all the big data that tells you 75% of Syrian people have PTSD and 67 have depression. That's nonsense. You can't have that in a society. By definition, if the majority of society have PTSD, then we need to rethink what PTSD is. You can't have the majority of people having mental illness. You can't have a whole population of mad people. That's just not possible. Okay? So, refugees are not a homogeneous group that we just give a prescription of cognitive behavioral therapy or Prozac or whatever to. Each person comes with a whole host of individual personal experiences that they go through that needs engaging with and exploring and thinking about with them. When they asked refugees themselves, what are your most pressing needs? Very few of them said, I need some help for my depression. They mostly said, I need employment, I need settlement, I need to bring my family, I need to learn English, I need a job. And yet, as healthcare professionals, we often look for the symptom, don't we? Because that's what we're trained to do. So there's something here about training for doctors, which hopefully AskDoc are trying to also kind of address by bridging this gap between what community needs and what we learn as doctors in medical school. PTSD is a very Western concept coming from kind of the war in Vietnam and compensation for soldiers and so on. It doesn't quite fit our communities and societies. It doesn't help to go looking for flashbacks with people. If you ask every Syrian person who's been through the war, have you had flashbacks, they will say yes. That doesn't mean PTSD, and often approaches don't help. Approaches that work with PTSD in a soldier, American soldier in Iraq, or in Syria for that matter, don't help for a victim of detention and torture and sexual violence in one of the regime's prisons in Syria. Both of them have PTSD, by the way. You might diagnose them quite comfortably with PTSD. So the consequences of this approach, I'm arguing, is that it ignores the culture of the historical, the spiritual contexts, and the meaning that people ascribe to their experiences, their horrible, difficult experiences. They have a meaning to them, and I'll say a bit more about that when I say what I did in my own study. It ignores people's genuine suffering and needs. As I said, they tell you they need this, and yet you give them something else. It ignores the post-migration experience that people go through in the UK. And you only need to speak to a refugee here, whether they're still in the asylum process or they've been granted settlement, what they've been through since they arrived. And a lot of the time, it's not any less than what they've been through before coming to the UK. It often pathologizes normal behavior by presenting people's ways of adapting and coping as symptoms of the mental disorder. The final bit here is really important. Potentially re-traumatizing and invalidating. You think you're trying to help as a healthcare professional. You often, through this approach, you're often re-traumatizing, invalidating their actual true experiences. Especially when you tell them you have a mental disorder. The whole of my life and my situation is disordered. It's not me who's disordered. And I think that's really important. How can you expect people to remain sane in a very mad world, the world that they live in? So let's drop the disorder. Being a refugee in itself isn't a psychological problem, despite a lot of assumptions that are made to this effect. It's a result of the political and other factors and situations. Let's talk about ordinary human suffering. Ordinary doesn't mean insignificant, by the way. As opposed to a manifest psychopathology means mental illness or mental illness symptoms. And like I said, even people's responses that might be seen as symptoms of PTSD, people's flashbacks, those kind of repeated reliving experiences of trauma, are their ways of making sense of what they've been through. People's avoidance is their way of protecting themselves. People's numbing is their way of helping themselves cope with the immensity of their emotions. These are people's adaptive ways to cope with how difficult things are for them. They're not manifestations of an illness. So focusing on diagnosing and labeling people risks invalidating the true experience of refugees, portraying them as mentally ill, removing the political, social, and economic, and like I said, value and meaning-based contexts to their suffering. Dismissing potential and growth. If you tell somebody you're mentally ill, they wear this on their sleeves. They internalize, another way of putting it, that label. They become the disorder. They become PTSD. It's bad enough to give them the label of refugee, which will stay with them forever, even after they become British citizens and so on. But actually, when you're doing this, you're moving them from a refugee identity to a patient identity. By patient, I mean, in the medical sense, not somebody who's got great patience. Does that make sense to people? This question of internalizing a diagnosis that becomes part of your identity. I become schizophrenia, I become depression, I become PTSD. And then there's nothing else to me other than this disorder. This might apply to non-refugee populations, by the way. So we've got a double whammy here. People who are refugees or asylum seekers coming to the UK, for example. They come from a different culture as it is, but they also have all the experiences of being a refugee and asylum seeker. So you might need to adjust and adapt your approach for this bit, which is what you do in a city, Manchester, with lots of multicultural backgrounds and so on. You need to adapt and adjust your approach for this bit too, on top of that. So you've got a very difficult job. that requires cultural competence. So people express themselves in very different ways. They come from different cultures, but also if they were refugees and have had experiences of serious trauma. When I worked in Aleppo in A&E, I would get people who would say, I have pain in my heart, and they would put their hand in there, pointing at their stomach. Now the heart is up there. So, and you realize actually that it's a tummy pain, it's a stomach. That's just a very simple example. What they might present with through interpreters might be very different from how a white British perhaps person might express themselves and their symptoms. As we said before, the diagnostic criteria for PTSD or depression or whatever might not quite fit those people's experiences. And I think there is a danger here as doctors in us trying to fit somebody into a diagnosis, into diagnostic criteria of some disorder or another. We look at the DSM-5 and we go through the different conditions. DSM-5 is the psychiatrist's Bible that tells us all the illnesses that are there. It's been getting bigger and bigger over the years, DSM, from DSM 2, 3 to 5 that we have. So trying to fit people into those diagnostic criteria and then coming up with a diagnosis might not work because they don't present in the same way. People's way of describing their suffering might be very different. The narrative style might be very disjointed. What trauma does to people is it actually fragments your thoughts and your feelings about yourself, your memories. So you don't expect that kind of coherent, nicely flowing narrative that you would get from somebody who hasn't been traumatized over time. People's goals and needs might be different from what you think they need. A patient coming to their GP with back pain, this might be the presenting complaint, but what they actually might need from you, what might benefit them, might be quite different from what you think they need. So let's engage with them and think and talk to them a bit more about what they need from us. Working with interpreters, like I said, has its own challenges. I'm not going to say too much about that. Like I said, the challenges being the cultural, but also the fact that this person is a refugee or an asylum seeker who might be shut down, who might not even find the words because they're just so overwhelmed by their emotions that they just struggle to even speak in their own language. Word on trauma, I believe that it's being used far too often. I've had a traumatic journey from work, by the way, coming here. It's been really traumatic, it's very cold. I have to go through traffic from Stockport and so on. This is really traumatic for me. The threshold for thinking about something as trauma or traumatic has gone lower and lower. Everything, life becomes traumatic. Just being here is traumatic in life. And to the extent that when we use things so lightly, they mean nothing. They stop meaning anything anymore. And think what that does to the experience of people who have been through real trauma. The actual proper, the trauma proper when you're being, detained for no reason and tortured and your family members are being killed and raped in front of you and so on. I would say that is trauma, not my journey from Stockport. There's an assumption that trauma, i.e. a car crash, for example, is going to be traumatic. And I think there's a big logical problem in that, never mind, a problem that we see often, that it doesn't follow that having been through trauma, even in the orthopedic sense of the word, is going to be traumatic. Of course, the words come from very orthopedic, very kind of bodily literature, physical health. So let's not assume that just because somebody has been through what I might see as trauma, this event is going to be traumatic for them, and that people respond very, very differently to the same event. And you will all be able to recall family members who have been through a car crash, for example, or something worse, and they came out of it and they're fine. And some others who really struggled. And we don't want to go into why some people do this and others don't. That's beyond this talk. There is no inevitable outcome following devastating events. Like I said, the assumption that just because a Syrian person's house was demolished and shelled in front of their eyes, they're going to become PTSD, disordered, mentally ill, and so on. The interesting bit about PTSD is the first point, is the post-traumatic. Now we talk about post-traumatic stress disorder when you've got somebody who's been in a car crash and then they recovered. There's a post means after, doesn't it? Now, if you look at some of the experiences of some Syrians, some Palestinians, some other kind of similar refugees, there's no post, they're still going through it. This is still ongoing. Talking to them about post-traumatic event or post-trauma might be meaning that they're still going through the trauma. They through the home office asylum seeking process, through the treatment ongoing, through in the host community, through waiting for the UNHCR application to be approved in Lebanon, through this, through that. So talking about post-trauma becomes meaningless to those people. I'm advocating an alternative approach to the medical and the deficit model and the individualistic and all that. And I'm thinking we need to see refugees' ways of being on a continuum. On one end, you probably have those people who are, you might want to call mentally ill. I don't like this term, people with serious mental health problems. And on another end, you have got people who are adaptive, who are very well, who are doing better than you and me. Because compared to what they're going through, they're actually doing much better than you would think. And we need to admit that. And they might have a lot of strength and resilience and coping strategies that we need to learn from, rather than think of them as people who need our help. This is probably helpful for us to, as a host community, we want to feel helpful. Refugees' traumatic experiences can have negative, positive, or neutral consequences. The positive consequences can be related to re-evaluating my experiences, reflecting on what I've been through and coming up with new meanings that might facilitate growth and development for me. The concept of post-traumatic growth you might have heard about as well. And adversity activated development. This is a sense that you might not necessarily grow any better, but you continue to improve, and actually adversity helps you to move on. What doesn't kill you makes you stronger, type of thing. There are approaches that are based on the meaning, like I said, what meaning does the person attribute or ascribe to their experience and their suffering? Which in the West, we don't, as doctors, we don't actually engage with patients very much on the level of meaning. And it's not about religion or spirituality, it's about how do you see what's happening to you? How do you place it in relation to your existence and the rest of your family and community and so on? Refugees need to be seen as individuals with strengths and means of coping that they can draw on to survive, and we can learn from, like I said, as a host community. One of our Celebrating Syria festivals, one of the years, we've been doing it for 5 years, one of the years was an old woman, British, who asked me, I'm one of the organizers of the festival, and she asked me, so the money that you get from the festival, does it go to refugees? Does it go to help those refugees, Syrian refugees then? I mean, I didn't want to say, no, we don't make any money from the festival, but the important bit here is that sense of, I want to be helpful for refugees by seeing them as vulnerable individuals who need my help. I place them in a position of vulnerable people who need my help because that helps me. Helps my own self-esteem, if you like, ego, narcissism. That doesn't help them necessarily, does it? Because they want to feel that they're contributing something to this society as well, as taking from it. Whereas in nature, by definition, if a refugee has made it through, we've just heard about dozens of people dying in the English Channel, as I said earlier. By definition, people who make it to the UK through all this journey are resilient people. You know, they have strength and resilience that made it possible for them to make it. And we need to learn from that. Resilience there's so many definitions, but the bottom line is a positive adaptation against a lot of adversity, and I'm not going to say trauma. So it's about coming out intact, not necessarily better or stronger. And I think people often think, you know, maybe you come out stronger, but actually when we talk about resilience, we talk about remaining intact psychologically speaking after serious adversity. Have I got left? 5, okay. So contrary to common belief, resilience is actually the norm, is the common outcome of people's experiences, as opposed to PTSD or depression or anxiety. And I've said that before. People talk about kind of dancing forward as a way of again, describing people's experiences. Think to other concepts such as coping, adaptation, well-being, post-traumatic growth, like I said, but it's not any one of these on its own. Just because you are diagnosed with PTSD, probably wrongly diagnosed, but let's not go there again, doesn't mean you are not resilient. I think we need to be clear about that. And we need to look for those resilience factors in people and engage with them. And try and help people think about them as well if they're not readily able to do that themselves. Resilience buffers against negative impact of trauma and adversity, almost by definition. So a quick word about what I did. So I got a group of Syrian refugees in Manchester, in the UK. This was a couple of 3 years ago now, part of a master's degree, which I did alongside my psychiatry work. And I asked them about the factors, the things that help them carry on and keep going, basically, what I call the resilience factors. And with some interest in particular in the role of religion, faith, or belief system in aiding or perhaps hindering resilience. And without going into too much detail, these are the factors that came up. So by far the most important one was the interpersonal factor. That means people feeling the direct support from their families through the process of coming to the UK, before and through the journey and afterwards. Feeling the responsibility towards their family. I need to be strong because there are people who are dependent on me. If I break down, they are going to break down. That sense we're all in it together, to use Boris Johnson's or whatever it was phrase. We're all in it together. That's very helpful. If catastrophe is affecting the whole population, I'm not alone. The worst thing about people's experiences with mental distress is the sense there's only me who's suffering here. That sense of injustice. It's unfair. Still unfair, but we're all going through it. The second important factor was the belief system, or the faith, or the religion. People in the study come from different faiths, by the way, not just Muslim or Sunni or anything like that. And the idea that there is fate, that God has his own providence, like he knows what he's doing. This is all decided for me. Was quite helpful. Religion, or faith, was giving people a lot of protection against suicide. We don't see many. We have started recently in Idlib and in other countries in places in the north of Syria, seeing some suicide, but still a lot less compared to what you would have seen in a Western country. And there is a big assumption that, which I think is true, that religion and people's faith protects them from suicide. In fact, I came across a study, I think it was in Sweden, that showed that the rates of suicide amongst refugees were less than the suicide in the host community in Sweden. And I'll leave you to find the study, but also think about why that might be, along with religion as a factor. Religion providing meaning, going back to the meaning of our suffering, our experience, philosophy of life. Why is this happening to me? Protection, direct protection from God. People who had faith felt that God was actually there to help them go through the sea on the dinghy or whatever. Rightly or wrongly, I'm not here to judge people's faith. I might not think exactly in those terms, but that helped people. Who am I to say it's not important? The final kind of set of factors was the open up to people's personal factors to do with their values, to do with how they see the world in general. So they're hope and optimism, they're looking ahead. People were thinking, I'm going to come here, bring my family over, start to learn English, start to build a new life. And that kept them going. Their values kept them going. And various coping skills and defenses that people use. And just leave you with a couple of quotes from people, a few quotes actually, from people who I've interviewed. So when I crossed the Turkish borders, I felt as if my children were pushing me, as if they were saying, keep going. There's a Kurdish man. When I collapse, this is a young woman with a baby, when I collapse, the rosary beads will fall and people I love will also collapse. In other words, I have to keep going. This is about the providence, this is about the meaning. It's one of two things. It's either a test from God because he loves us, or in order for him to forgive our sins. In both cases, it's positive. And interesting. I mean, I'll leave you to make of this what you will. Again, it's not for me to judge whether that's what we should think or not, but that's how she made sense of her experience, and that helped. When I saw it with my own eyes, this is a man who crossed the sea. Now I realized that the chance of surviving would not be higher than 15%. People are managing to cross the sea with God's help, not with their own effort. Again, very interesting. When I see a dead flower, this is about optimism and hope. I don't want to see it as it is dead. I want to see it as a flower. So, be able to speak your mind. This is about values. To be able to speak your mind among people who are all not telling the truth. It is in itself a mission. That's the last one. We had to beautify. This is about people's coping. Now, looking at this, what is she describing? I appreciate maybe you're not far ahead in your medical studies to diagnose this symptom. This is dissociation, one of the serious symptoms of post-traumatic responses. If I were a doctor looking for a symptom and a disorder, I would diagnose this one as dissociation. I would stick her on some medication or something. We had to beautify reality in order to convince ourselves that there's no trouble in the country. The country was being destroyed. She used the word, I'm sorry, I didn't realize, she used the word, we dissociated from reality. Sometimes. But that's her coping strategy. That's what she employed, probably willingly, consciously, in order to keep going. And again, who am I to say this is a symptom of a disorder? This is, who's this guy? We've seen this picture before. So Steve Jobs at Calais, isn't it? Fancy. And this is from one of the volunteers in the study I did, one of the subjects. I'm the kind of person who has a goal. When I have a goal in my head, I feel reaching this goal will require a lot of work. It won't come easily. Nothing comes easily. Even when I arrived to London, I did not feel that I am done with my mission. He wants to go further. I felt I still had a way to go, but I went through it rather too quickly. I felt I needed to still continue to Canada or America until I finished a bit too soon. So that's all I have to say, I think. If any of you is interested in working, doing an internship or volunteering with Rethink Rebuild Society, look it up and get in touch. We do respond to our emails. And I think we've got a few minutes to answer questions. Is that right? Or comments?
Yeah, sure.
Or objections or criticism, or if you have any tomato or eggs you want to throw?
Thank you, Doctor, for sharing. Definitely shared a lot of stuff for us to think about, and I'm sure many of you in the audience are from a medical background, and often as healthcare professionals we love our labels, so definitely something to think about. I'm going to open it up to the audience. Any questions, because Dr. Mustafa will have to leave after this bit, so we'll just be taking questions for him now. Okay, so you mentioned sort of thinking outside the DSM, the medical model, when working with refugees and asylum seekers. But I mean, when we come to sort of like deal with these people and help them,
I guess a lot of it comes down to improving the circumstances of the refuge, but also does that like change in mindset with regards to diagnosis translate to any sort of like interventions or anything that we think about outside CBT and other helpful or other interventions that you described as being sort of like based on the Western model? Is there anything that this thinking provides outside the already established treatments?
Yeah, absolutely. And I think even psychiatric care and GP care is moving more towards this way of thinking, this kind of more holistic, or not holistic as in acupuncture, stuff like that, but more kind of what we call in mental health biopsychosocial models. So you, rather than thinking of people in relation to a set of symptoms that you kind of apply a diagnosis to, you think of people as responding to circumstances. This doesn't just apply to refugees. And there, you know, the concept of social prescribing, for example, is a common concept in mental health care and healthcare in general, kind of helping those people get better quality of life by doing things that would improve their confidence, improve their social life, improve their day-to-day existence, as opposed to focusing on. And again, social prescribing is more about looking at what people are good at and trying to build on that, what people are interested in and try to help them find that, as opposed to what people are not good at, i.e. their deficits, their symptoms, their problems, and trying to treat that with medication or psychotherapy. By the way, I say the same thing about medication or psychotherapy. I'm not advocating psychotherapy for refugees either, even though I'm a psychotherapist. Does that answer your question?
Yeah.
Thank you so much for this presentation, and thanks for bringing up the post-traumatic disorder as not only post, but it's also important to think about the journey of migrants and how they can be traumatized on every occasion. I come from Lebanon, where refugees are traumatized very often. And it's also important what you said about white people who think that they want to do something good because it feels good for them, and not necessarily because they really want to help this vulnerable person. So it's not only that humanitarian aid here in the West is not really working out for refugees the way it should, but it's also that people in the West, they go to these countries like Lebanon, like Palestine, and they want to help, like the intention is good, but what happens is that they sometimes create more harm than good when dealing with refugees, because they also import these ideas of CBT, PTSD, and all of that, and that creates a lot of problems for the refugees. And I hope that there's someone from MSF here, because the work from MSF in Lebanon is not that great, and that's because they are bringing ideas and people who are not very aware of the contextual situations of the refugees in Lebanon and what's happening there. And there are instances where refugees are really getting in, like if they had some trouble, like if they are depressed or whatever is going on with them, it's becoming even worse because of this not very well thought of humanitarian aid interventions. So it's not only here, but it's also what gets imported from here to other countries.
I agree to a large extent, although I'm not in a position to comment on NSF's work in Lebanon. I don't know much about what they do there. But it's not just organized, it's individuals also like me, perhaps, in my position, who are really full of the desire to go and help. I've heard of psychiatrists doing kind of bedside EMDR, which is kind of the eye movement, another nice guidance, approved treatment for post-traumatic. They're doing it by the patient's bed, with, in a day with another 10 people or something like that. And you know, kind of it's almost like becomes something that's very quick and easy. Of course, it's not quick, it's not easy, and it doesn't help. So I agree with you. Absolutely.
Sharing community and change-dissociative reality, and you said that if you saw that in clinical situation, you would see it as a symptom of PTSD. But can't it be argued that is a positive coping mechanism and it doesn't need to be necessarily medically treated? So why would you treat that in clinical setting?
That's exactly what I'm arguing. Yes. Yes. So I hope none of you will treat this kind of person with as a PTSD or as mentally ill, because exactly that's what I'm saying. It is their way of adapting to a situation. If your reality is so upsetting, you're going to look for another reality, virtual reality or anything else for that matter. You're going to invent your own. That's what psychosis and dissociation are about. They're not the same thing, by the way. So you don't say psychiatrist, say psychosis and dissociation are the same. Any other questions or no? Brilliant. Thank you.
Thank you so much.
That's a lot.
So guys, just last bunch of the time, we're going to move on to our second talk today. So with us we have Dr. Aisha Awan, who is the director of the Refugee and Asylum Centre, a healthcare professional, educator, great hospital. She's a GP and she's also a senior clinical lecturer at the University of Manchester. So today she'll be discussing with us the experiences of a refugee and asylum seeker navigating throughout the healthcare system in the UK, common health presentations of refugees and asylum seekers in a primary care setting, and pointers of communicating sensitively with refugees and asylum seekers and advocating for them in a healthcare setting. So,
great, thank you. So firstly, thank you so much, AskDoc, for having me. And I left Manchester University in 2002, having done 2 degrees back to back. So it's been a lot of time down this stretch of road. And I can't imagine having come to a talk like this with this kind of attendance about refugee and asylum seeker healthcare or any interest in this. And so firstly, thank you for being advocates for a really vulnerable group in society. It's really great to see that there is this enthusiasm here for you. Also, I'm not a senior lecturer, I'm just a clinical lecturer yet. I haven't done all the paperwork required for senior lectureship just yet, but sometime in the future. So another declaration of interest, as Mustafa did as well. I'm not far removed from this, so I'm not a refugee, but I have lived through a war and I've had to leave my home because of war. But it was not in the same way that somebody who has left their home country and the only home they knew had to leave. So I am not completely absolved of all interest in this area, and it is something that's really close to my heart. But yeah, so that's a little bit about me. Now, firstly, I like more interaction, so I'm going to give you guys a couple of scenarios to work out. But before we do that, just from your own experience, what do you think some of the challenges might be for refugee and asylum seekers trying to get healthcare in the UK? So just off the top of your head, what kind of issues do you think they might face? And think about yourselves going to another country. Yeah.
Language barrier.
Language barrier, fantastic. Yeah, number 1 on my list too. So can you think anything in particular that you're thinking about?
Just English is quite difficult, so about I guess.
Yes, English is quite difficult. Yes, English is very, very difficult, particularly northern accents. Now, I came to the UK when I was 14, and my English teacher was from Wigan. I'm sorry, my maths teacher was from Wigan. Despite being adequately performing in maths, my grades plummeted because I was too afraid to tell her I didn't understand what 50% of what she was saying actually meant. So accents make a big difference. Slow down, speak louder and clearer, and just ascertain that they don't have a degree in English before you start slowing down and speaking louder as well. So, you know, language is a huge, huge thing. Using colloquialisms, okay? So calling somebody love might be deemed very offensive if their partner is sat next to them. Just be careful about the language that you use. So communicate clearly. Nodding head and nodding head don't mean the same things in different parts of the world, okay? So nodding head can mean I totally disagree with you when you are chatting absolute rubbish, okay? And this can mean yes, okay? So ensure that you understand what the person's actually saying to you. So check and repeat. So chunk and check. What kind of year are you guys in as medical students, right? Is everybody a medical student firstly? Anybody not a medical student? Okay. Anybody not in a healthcare type degree? Super, so that's fine, that's useful to know. Anything else? A language barrier is one. Anything else you can think of? Anything else? Any barriers to healthcare? Yeah?
Financial barriers in that field, like they're not taxed as free healthcare.
Absolutely, yes, that's a big one. They don't realize that healthcare is free. Although the vast majority of people are aware to some extent because when they come to the UK, they know that, you know, it's well known that healthcare here is free. But you're absolutely right. They might not know how to access it or where to go. Do we go to accident emergency where they turn you away? They go to a pharmacy to try and buy antibiotics. That's not the norm here. Going to an out-of-hours center. They don't know how to access healthcare. What is the correct way? Calling NHS 111. We'll go through a little scenario of what we're going to do in terms of what it's like to actually be in somebody's shoes who's trying to access healthcare from a vulnerable group. So, in terms of finances, does anybody know approximately what a refugee or what an asylum seeker gets per day in the UK from the government? Yep, it's £5.66 to survive on. Okay, so that's £5.66. That's about £1,900 for the whole year. Okay. Now, if you just think right now, you're students, life is, you know, pretty fine on the financial barriers to what you can and can't do. Think about your mobile phone bills, think about food, think about transport. Where are you up to in the week? Does that cover it? Doesn't even touch it. So there are huge financial barriers here. These are the people buying the yellow sticker items in supermarkets. These are the people going to charity events, picking up shirts, having donated items. But back home, they might have been a neurosurgery professor. They might have been a pharmacist. They might have been an engineer. But they're here, they're resorting to going and buying things that are the cheapest. So one of the refugees, for one of my asylum seekers at Reach, submitted his receipts. Unfortunately, we have to put them through this indignity, because that's what we do in the NHS. You know, the NHS doesn't cause indignity, but we have to submit lots of paperwork in order to get the funds back. So he submitted this receipt, and on it was 6p for a pack of bananas. And you know that he's gone for the yellow sticker items. He's gotten he spent £1.20 on shopping for the week. So just to try and put it into perspective, it's a different way of living. It's not something that we're accustomed to. The financial hardship is there. Anything else? So we said about, yeah.
They don't have a permanent address, so that makes things really difficult, especially in primary care.
Excellent. Yeah, that's a real challenge. So when you put down that your address is either a hotel or you're moved from the barracks that we've all read about in the newspapers to another hotel to another place of residence, it's very difficult to give a permanent residence, which makes it very difficult to get benefits, which makes it difficult to access healthcare, to get a data plan set up, to buy things. So, okay. In a way, being a refugee or asylum seeker, it destines you for suboptimal care. You're a vulnerable group. So what are some of the things that you can do to counteract some of this stuff? Okay, so what is some of the stuff that you guys can think of? If you're in a consultation, is anybody a third year here? You're fourth year yet? What are the kind of things that you might think in consultations that you could do?
You can use a translator.
Good, yeah, so language, using an interpreter or a translator. look at the difference between the two. They're very different roles. Excellent. Anything else? Yep. Okay. So one of the more common things is try and bear with me 1 second. Two computers here. So give them at least a double appointment. Okay, at the very least, give them a double appointment. So that is, rather than 10 minutes, you give them 20. In some cases, it will need more. Book them in at the end of your surgery, so they've got that ability to have time to speak to you. Because the last thing you want to do is push somebody along when they already have issues talking about how they're feeling, language barrier, and lots of other things. And sometimes just getting it off your chest is the best thing that you can do for them. Somebody in a position, a privilege, and authority, listening to them is often the best medicine that they can get. Psychological support. Now, I didn't write psychiatric support here because I completely agree with Mustafa. There is a degree of over-medicalizing the situation. Peer support, local community support, accessing mosques or churches or local religious groups, or for people to get support from within their own community is really helpful. Okay? And it's not difficult to make those bridges. So do contact local groups. Find out local refugee and asylum seeker organizations that work. You know, Mustafa works for one, I've worked for one, and we're happy to offer support and help. Okay. Explain how the NHS works. Say for minor illnesses that people should go to a pharmacy in the first instance. That actually the way to access healthcare, the vast majority of cases, if it's not an emergency, is the GP, and that they should register for one. Let them know what is appropriate for A&E and what's not, because A&E in itself can be quite a traumatic experience that rips off old wounds. Because one of the things that refugees and asylum seekers are used to hearing a lot of is the word no. Okay? The word no, or you can't, or that's not going to be possible. That's a traumatic experience again and again, because they've had to hear those terms repeatedly through their journeys to this country. And here when they've arrived as well. So try not to use no. Try and use affirmative positive language in how you communicate. Managing anger and emotion. So don't confuse anger being directed at you. Okay? It's not being directed at you. It's because of all the stuff that's gone on. So you are there as a compassionate listener. You can allow them to be angry. The vast majority of them are unlikely to physically harm you in any way. And actually, you know, I've had very, very angry, very large men in the room who I've never felt threatened by because I know that anger is coming from somewhere else. Keep yourself safe by all means. Do the stuff the psychiatrists tell you to practice. Make sure you're close to the door and all that. But open body language. Listen. Be a compassionate listener. It's really easy to nod your head and say hi, but actually listen. Say back what they're saying to you. Reflect their emotions. Sometimes you don't need to fix it. Affirmative language can be just as well. Feeling actively heard can be a really good source of support. Treat them as individuals. Now, Mustafa also touched upon this. Don't say you are a refugee or an asylum seeker. I've made that mistake far too many times. And one of my members just 2 weeks ago, I was dealing with a situation with one of our academic supervisors. And I said, you know, it's a huge pressure and burden being an asylum seeker or a refugee on the wards. She's passed her GMC, and she said, I'm not a refugee. That's not my title. My name is, and that's who I am. So I don't want to represent refugees. I wasn't born a refugee. That's not who I am. And that really hit me right to the core. And I made that mistake plenty of times, but treat them as individuals. They weren't born as a refugee or asylum seeker. That's not their identity. The world sees them that way, but that's not who they are. They are individuals and treat them as such. Now, I've done this very much on purpose. Think about outside somatization and then somatization. So what is somatization? Does anybody know what that means? Here's some. Okay, so somatization is the psychological symptoms coming out as physical symptoms. So people experiencing weakness or fatigue or tiredness. And actually, it's coming from psychological distress. But before you jump to that, you must exclude medical causes. So One of the reasons doctors often, or one of the reasons that vulnerable groups, such as refugee and asylum seekers, such as Black women, get poorer healthcare in the UK is because a lot of emphasis is put on somatization. Oh, they're just somatizing, it's absolutely fine. You know, she's had abdominal pain for 6 months, it's fine, you know, we've done an ultrasound, we've examined her tummy, everything's okay. But lots of things can change in 6 months' time. I've seen plenty of people who have missed cancer diagnosis, endometriosis, other pathologies that go undetected because of somatization. So before you state the label of somatization, make sure you exclude medical causes. And periodically, if they keep representing, if somebody represents more than twice for the same thing, you must look at it again. It may well be somatization, but you don't want to be the doctor, and you don't want to have the patient that you've missed that diagnosis on. Okay, so keep engaged. It's very easy on a busy clinic to say, right, that's just mental health, that's okay. It's never just mental health. Either way, there's support required. Now, I'm going to talk very quickly about Samuel, but before I do that, I just want you all to stand up. Okay. So, right now, I want you to make your minds blank, and we're going to split you guys into rows. So, you know, these 2 rows here, rows 3 and 4, and then the back row. You're all going to get one person that you're going to be, and I want you to stand as far back in your row as you can do. I'm going to give you a scenario. You're going to be that person. And you're going to take a little step forward if you can perform the action that I say. Okay. So these first 2 rows, you're going to be a government, so you're a refugee in this country. Okay. You're a government official from Iran. You're a refugee. Your phone's out of credit, but you can make 1 phone call because your phone company allows you to make 1 call. You have really poor English. You can communicate hello and I need this, but very basic information. You've been in the country for 27 days and you were moved from Birmingham to Manchester a week ago. Okay. The second group of people, you're a Malaysian medical student at the University of Manchester. You're in a same-sex relationship. You don't have a car. Okay. So that's your background story. And the final group, you're an Afghani engineer. Okay, you're a refugee. You have 3 children under the age of 5. You live in a flat in Salford. Your husband's disabled because of a spinal injury. He lives at home with you and you're his primary carer. You have money, you have a phone, you know where the local hospital is. Okay, and all 3 people have excruciating abdominal pain that's developed at 9:30 at night. Okay. Now you're at the back of this row. I'm going to read out a scenario and I just want you to take a small step forward if it's something that you think that this individual would be able to do. So you want to make a phone call to the hospital, which is what you think you should be doing. So can you make a phone call to the hospital? Take a small step forward if you feel you can do that. Okay. You realize, whoever did it, which people could bring me out? You realize that's not what you have to do. So you try and call, you call this number at the hospital, they tell you to call NHS 111, automated message. Can you understand the automated message to call NHS 111? That talks at the speed currently that I'm speaking at. You've made your 1 phone call. Can you understand the automated message? Take a step forward, okay? If you can't, stay where you are. Now the next thing is, you've now got to call NHS 111 and speak to somebody down the phone and explain your symptoms. Can you do that? Okay. They tell you to take a cab or use transport to walk or go to the nearest hospital. Do you feel you can do that? Can you do that? Okay. Right, our medical students do it quite well. When you get to the hospital, the nurse triages you. Okay, and tells you that you'll be waiting in the waiting room for about 2 to 3 hours. Can you do that? Hey, you're still not at the hospital. Okay. For those who aren't at the hospital, I now want you to imagine by some miracle, because a ferry has appeared, that you guys have ended up at the A&E department. Okay, so just stop there and you're now at the A&E department. Okay. They tell you that you're going to be there for 3 to 4 hours. You're quite angry, you've got a lot of responsibility. and you now have to wait. Are you able to wait? If you can't wait, stay where you are. If you can wait, take a step forward. Right? They explain to you after examining you and taking bloods, and the doctor sees you, that actually your pain is likely due to constipation, and they prescribe you some laxative and tell you some information about your diet and what you're eating. All of you have been living mainly off processed carbohydrates because that's what your income can afford you. So you've not been having a lot of raw food and diet. Medical students, well, he just likes carbohydrates anyway. So are you able to understand that information? Okay. Take a step forward if you can. You guys are pushing the desks forward now. Can you afford the medication? So you go and you've got to pay for this prescription. Can you afford the medication? Okay. You need to make it back home. Do you know how to get back from the hospital? Or can you explain to the taxi person how to get back from the hospital? Right. Now take a seat. How does that feel? Any thoughts about how that experience felt, being in that position?
Helpless.
Helpless, yeah. Any other emotions in this group?
So completely out of control.
Yes, absolutely. And how does being out of control make anything?
So scared, a little bit anxious.
Scared and angry, yeah, and anxious, absolutely. Okay. The second group. What I did, and you probably don't know this, but often there is a deep distrust of people from official figures. So in many countries, doctors are seen as part of the establishment. So a medical student from a certain part of the world, and Malaysia might not be one of these countries, but for example, an Iranian gay doctor or a gay medical student might not want to come and openly state to a medical doctor that actually has gay. And, you know, I've had this abdominal pain going on for 6 months. I know I've not had an STI screen, and, you know, miss out that entire part of the consultation altogether. So be mindful. Explain to them that what you say is confidential, that it's not being shared. So understand that people might come from healthcare settings where they don't understand that your authority and privilege doesn't mean that you will go and share that information with anybody else. Okay? And the final group, what were the kind of barriers that you felt? No. The kids, maybe? Yeah, we have lots of other kids. Sorry?
Like the 2 kids under 5 and like the husband who like fully disabled the country as well. So that is a factor in terms of who's going to look after the kids and how that situation.
Absolutely. Who's going to look after the kids? My husband can't do it. How am I going to do it? I'm not going to go and get healthcare. So this possible abdominal pathology is going to keep developing into hemorrhoids, cause pain, that causes your mood to drop, and that causes depression. Okay, it might not be the entire journey to this country, but then the inability to access timely healthcare causes that repercussion of pain and the impact on mental health. Right. Now I'm going to tell you a story about Samuel. That's not his real name, but this is a real person who is a REACH doctor. So at REACH, we train refugee and asylum seeker doctors and nurses and other healthcare professionals to regain their registrations. They can work in the NHS again in their professions. They've had over 500 people pass through our programs, which we started 18 years ago. And, you know, many of them have gone on to NHS careers as doctors, as consultants, as dentists, as physios, as nurses. And it allows them to have their identity and their life back in another country. Okay, and I'm very passionate about it, care very much about it. If any of you want to get in touch, I'll give my email address, but also got my Twitter thing at the beginning. Just drop me a message, because we're always looking for volunteers, and the medical students, frankly, are fantastic. We have lots and lots of medical school volunteers who come and speak English with our members, help them with some of their clinical skills training. They'll help us develop materials for them as well. So Samuel arrived here from Eritrea. Really traumatic journey, completely isolated, and sought asylum. He was sent in the barracks where there was an outbreak of COVID, and everybody got ill. 3 of the people who were sharing his area with him died, and he was traumatized by that experience, highly traumatized. The journey here was bad enough, but that experience of being in an area that was so filthy and disgusting and where he was dehumanized affected him as well. He was effectively homeless when he contacted us and said, I'm a doctor, this is my training, how can I get over and start training with you guys? And he wasn't in the area, so we had to arrange for him to have accommodation here. That takes time, it's difficult and challenging for asylum seekers. We spent a period of time homeless where we contacted his local church, and they thankfully were able to get him into some local accommodation and housing. And some of the excellent volunteers at the church were able to get him food and get him meals for a period of 2 weeks while we got him over. Samuel developed excruciating abdominal pain and went to the local hospital. He walked there with pain that was scoring 9 out of 10. He got to the hospital, was seen by the doctors, and was reassured that it was nothing significant, but they couldn't quite tell him what it was. And he was told to go home. Now, he had taken 2 journeys on the bus to get there, but his money had run out. So he tried to contact the taxi firm and said, I need a taxi. They were like, where are you? He said, well, I'm at the hospital. But where in the hospital? He went and spoke with the registration person at the desk, who wasn't able to offer him any clarity because he was talking very slowly. Now, Samuel's a very soft-spoken, lovely guy, and he doesn't raise his voice, and he talks like this. And his English isn't fantastic, but it's good. And they weren't able to help him because they didn't understand that he didn't know where he was and what he needed, and they didn't ask, and he wasn't able to do it. So he called me and said, I'm at the hospital, I don't know what to do, I just need to get home, I'm not feeling particularly well, they've given me some pain relief, but I just need to get home. I arranged for a taxi to pick him up from the hospital, but the taxi driver didn't understand the address that he wanted to go to, so left him there. It's challenging. He then went for his vaccination, his COVID vaccinations, as the same person. And we had organized with Salford Royal, which is an amazing trust that has hosted REACH for 18 years, do lots of social outreach, do lots of involvement in working with disadvantaged and disadvantaged communities within the local footprint. And he went for his vaccination, and he's a young, Black, refugee doctor. And he was turned away not once, but twice, because he didn't look like or sound like what people thought a doctor should look and sound like. So again, he heard this word, no. No, you can't have this. No, that's not right. And he was entitled to it. So just living in Samuel's footprint, this is a real person. You begin to understand just a snapshot of what it's like to be this individual. And he's a professional, he's a doctor. Imagine what it's like for those people who aren't aware of medicine, who don't know what they are entitled to or what they can access or what pain is or what's dangerous and what's not. Okay, so we talked a little bit about what we can do and what we do at REACH and what we do at REACH. Can I just ask how much more time? 2 minutes, 2 minutes, that's fine. Okay, so at REACH, we, like I said, have been working at Salford Royal for 18 years. We train refugee and asylum seeker doctors so that they can work in the NHS. And I just want to share a reflection that one of our doctors did. I'm sorry it's so small, so I'll read it out to you. So this is Yusra. Yusra is one of our members who's not able to work because she's an asylum seeker. So refugees can work. Asylum seekers do not have an automatic right to work in the UK. So it doesn't matter that the NHS is short-staffed with doctors and nurses. People who are qualified and have passed their GMC registration exams cannot work. Okay, so she's banned from working. And she described how she got into medicine. So my decision to become a doctor was driven largely by my values instilled in my heart by my faith. Background from academic parents, coming from a country which is torn from wars, consequences where medical support is a must. This profession is focused on helping others regardless of their circumstances. Facilitates people leading healthier and thus happier lives. I knew from an early age that medicine was a career of pain. For feelings towards your situation of not being able to work. It's a job requiring intense schooling, constant training, and heavy dose of tenacity and patience. It's not something you give up easily. And for me, it was as important as breathing, eating, and seeing. I just couldn't digest the fact that I wouldn't be allowed to practice anymore, merely because I had sought safety and fled my home. I have become a joke to my extended family and friends. Their favorite joke relates to the amount of time I've spent to graduate, to train in hospitals, and the time I've spent sitting exams to meet UK standards, which every junior doctor in the UK knows is no laughing matter. Though I got here, I was faced by the reality of being an asylum seeker, which means I'm not allowed to work. This wasn't the end of the story from my point of view. I was determined to see a light at the end of the tunnel. Volunteering could be an option. I quickly realized I will take my part and stand with my colleagues in the front line by doing unpaid work. She worked during the pandemic in a hospital voluntarily, okay, without pay. The pain and stress I paid to reach this was massive. I doubt I would forget it for the rest of my life. It took months to get placed back in hospital. However, this experience is very fruitful. Volunteering is a great work experience option. With COVID restrictions in place, it would boost my CV, help develop my own skills. It also opened the door to build relationships as well. It absolutely shows my commitment and motivation and gives it plenty to mention in my personal statement. These are tenacious, strong individuals. Treat them as such. Okay. Thank you very much for listening. If you have any questions, please feel free to ask.
So we'll open it up for questions. So anyone have any questions for Dr. Aisha and Dr. Patricia? Anyone has?
So did Dr. Yusra end up practicing fully?
Yusra has got a job, a paid internship, as they call it. It's not where, it's not a paid junior doctor job, but she's doing a paid internship. And we've got a legal team working on getting her the right to work, which more and more asylum seekers are able to apply for, but it costs a lot of money to do that. So we're helping her with that process. So hopefully, in the not too distant future.
And so you mentioned about like volunteering and medical students. Is there like an email address?
Yeah. So it's reach at manchester.ac.uk. So it's the same as your email addresses, but just reach, REACH. Or you can tweet us at Reach Northwest, and happy to help out. Or you can search for me in the directory here at the university. So it's Aisha Awan, AISHA AWAN. Just drop me an email and I'll happily pass on details. Okay, right. Thank you so much.
We'll share some kind of how the medical professionals can make a difference, and also sharing real life stories, because it really does make you think that these are actual individuals with lives and stories, and it's when you did the exercise that we can't even imagine living in a life like that. So thank you so much. Our final speaker of the event. So many of you will have seen our Instagram posts and social media about Dr. Ahmed Hankir. And yes, he was supposed to be attending this event in person, but unfortunately things do have to come up last minute. I know Dr. Ahmed Hankir was also very excited to be in Manchester, the first event in person after the pandemic. But unfortunately, he was called in to do emergency cover at the hospital, so wasn't able to make it. However, currently he has joined us via Zoom. So a warm welcome to Dr. Ahmed Hankir.
Thank you so much. Thank you. Can you hear me clearly? And can you see me? It's great to see you all. Is it like a big screen? And because I'm tiny on this screen, and do I look huge to you guys? Okay, cool. I'll just need to share my, oh, there we go. Not very tech savvy, but I think I can do this. So yes, I was really looking forward to giving a face-to-face presentation, but I got called in this morning by the head of the School of Psychiatry at London, and they asked me to cover a shift. So I'm really sorry, but I promise you that I'll do my very best to deliver this talk with gusto and with passion and with urgency, and it's a topic very close to my heart. So I delivered a similar talk to the entire workforce of the World Health Organization And I thought I would give this talk to you all, if that's okay. There's some overlap. I thought the other talks were fantastic, and I feel very fortunate to share a platform with the other speakers. So let's dive in, shall we? So I'm Dr. Ahmed Hankir, and I identify as a wounded healer. So I'm both a mental health care provider, an NHS psychiatrist, and a mental health care receiver, a psychiatric patient. So there is a perception that doctors should be invincible, but the reality is that we are human beings, that we are fallible, and that we are vulnerable to developing mental health problems like everyone else. I wholeheartedly believe that we can harness the colossal power of storytelling to humanize people with mental health conditions. So this is my story. I'll never, ever forget the date, 10th of July, 2000. I was in Rafiq Hariri, Beirut International Airport, saying goodbye to my family. There I am with my father, the Honorable Dr. Zakaria Hankir, and I'm going to get emotional because I haven't seen them for so long. I'm sorry. So the situation in Lebanon back then was terrible. The situation now in Lebanon is terrible since the...
She what? She ignores you.
She ignored that as well, but she annoys me when she does.
I don't think I can hear someone. Sorry. Sorry. That really okay, let's try that again. So the situation in Lebanon is terrible now. 60% of the population living below the poverty line. This was since the devastating explosion in the port in Beirut. I think one of the largest non-nuclear explosions in history. It had far-reaching consequences. So back then, my father purchased a one-way ticket for me to travel to the UK with high hopes for a better future. And I don't care if this shatters my masculine bravado and toxic masculinity permeates the Middle East and North Africa region. I was crying inconsolably. You know, many of us migrate or move to another country, not because we want to, but because we have no other choice. So upon my arrival on British shores, I naively thought that I would just waltz into university and that I would be embraced by the academic community. I graduated top of the school that I attended in Lebanon. So I didn't think it was too far-fetched of me to have that belief. However, this belief couldn't have been any further removed from the reality. My qualifications from Lebanon were not recognized, and I was a janitor cleaning floors in the morning and a stock advisor stacking supermarket shelves during the day and night. I was working 70 hours a week on minimum wage just to put a roof over my head and food into my stomach. Now, how did I feel? I was 17 years old at the time. I was just a kid. My mind was still maturing. My brain was still developing. My heart was still growing. I didn't understand why when I would say good morning to colleagues at the workplace, they wouldn't say good morning back to me. And it's quite topical, isn't it? Racism. And this was in Leeds, by the way, and Azim Rafiq has been honest and open about how racism was hugely detrimental to his mental health. And you think that is limited to cricket? I mean, let there be no mistake. It's a reflection of how deeply entrenched racism is into the fabric of British society, especially in Yorkshire. People would look at me as if they were disgusted, as if I was a beast, as if I wasn't even human. And that's not an overreaction. That's how I felt at the time. I mean, if you're a professional and that's how you're being treated, what if you're not a professional? And you don't have, in Nigel Farage's words, skills. How does British, you're not welcome. According to Nigel Farage, you can only come to the UK if you're a migrant with skills. But if you don't have any skills, then you are not welcome here. You are useless. So I would see kids my age living with their parents, preparing to get into university, and I felt melancholic. Of course I did. However, I was fully aware that I had been given a decent shot at life. Education in the UK is a birthright, and that is not the reality for the majority of people on this planet. And I would admonish myself if I squandered that golden opportunity, if I took that opportunity for granted. Shame on me for taking that opportunity for granted for a moment. I just had to be patient and stay focused and work really, really, really hard. And in the following year, I enrolled into the sixth form college, and I continued to work full-time hours to survive. And the head of the sixth form at the time asked me, what do you want to do with your life? And I said, it was always my dream to become a doctor. And she immediately laughed in my face and scoffed. Medical school is too competitive. You'll never get in. Choose another course. She didn't have to say it, but she made me feel like I was this dirty little immigrant with delusions of grandeur. Her words hurt me. Her words hurt me a lot, but I did not allow her to diminish my resolve. Despite the constant threats that working full-time hours posed, I secured straight A grades and I matriculated into Manchester Medical School. Then in 2006, when I was a third-year medical student, I woke up one morning to discover that my hometown in Lebanon was bombed and that hundreds of people were killed overnight. My nightmare turned into a reality and my world turned upside down. I saw harrowing and horrific images of dead bodies strewn on the streets of Lebanon, decapitated and disemboweled babies being removed from the rubble. I felt powerless and overwhelmed, and I feared that my family were among the dead. Unbeknown to me, they were evacuated by the British government. I was unable to get through to them. And I developed a severe episode of psychological distress. However, debilitating though the symptoms of psychological distress were, the stigma was far, far worse. I was marginalized, ostracized, dehumanized by people who I thought were my closest companions at the time. And I was forced to interrupt my studies. And my only source of income from the student loans company was severed. I was rendered impoverished, hopeless, and homeless. And I was sinking deeper and deeper into the darkness. Now, in my despair, I contemplated suicide. However, as a practicing Muslim, I was aware that suicide is forbidden in Islam, and this deterred me from acting upon thoughts of ending my life. My faith was a protective factor. My faith remains a protective factor. It continues to contribute to my mental health resilience, and it certainly contributed to my mental health recovery. I eventually sought informal support from my imam in my local masjid, who urged me to seek professional help from an NHS psychiatrist, which is what I did. I gradually recovered and resumed medical school with a renewed determination and resilience. There was a fire burning in my belly and thunder in my heart to realize my potential and to empower and dignify people with mental health conditions. And I finally qualified against all the odds. However, my journey had only just begun. I had been rejected and ridiculed and humiliated for so long. I was inspired to work above and beyond the call of duty, and all the heartache, all the sacrifices and suffering paid off, because from leaving my family behind me in Lebanon when I was 17 years old, from cleaning floors and stacking shelves for 70 hours a week to put a roof over my head and food in my stomach, from getting into medical school and then experiencing psychological distress triggered by the Lebanon war, to being forced to interrupt my studies, to becoming hopeless, homeless, and suicidal, then recovering and qualifying. In 2013, I received the Royal College of Psychiatrists Foundation Doctor of the Year award, and the RC Psych Awards mark the highest level of achievement in psychiatry in the UK. And I say, that's not bad for a madman. And then some people were thinking, maybe he was lucky. So you know what? I went and I did it again. And I received the Royal College of Psychiatrists Core Psychiatric Trainee of the Year award. And I hope and I pray that my story is further evidence to prove that not only can we recover and function again and achieve excellence, but people with mental health conditions can be the best at what we do. I didn't become Doctor of the Year despite my experiences with mental health problems. I became Doctor of the Year because of my experiences with mental health problems. Without a doubt, I'm not only a better doctor, I'm a better human being. I've become more insightful, I've become more driven, and I've become more empathetic. I remember when I would say good morning to people and they wouldn't say good morning back to me. And now in my capacity as Doctor of the Year, Professor of Academic Psychiatry in Cape Canaveral, USA, whenever someone says good morning to me, regardless of if they are a janitor or a professor, I always say good morning back to them with a big smile on my face and in my heart. What is stigma? What are the consequences and what can we collectively do to challenge it? So Irving Goffman defines stigma as a deeply discrediting attribute that reduces the better from a whole and usual person to a tainted and discounted one. The individual is thus disqualified from full social acceptance. So what is that deeply discrediting attribute? It could be having a mental health condition or disability. It could be your ethnicity. And as I mentioned, we know that racism is a huge problem, especially in the global north. It could be your faith. We know that Islamophobia is on the rise in the West. So intersectionality is a phenomenon whereby a person has layer upon layer of deeply discrediting attributes. A person of color with a mental health condition and a disability who identifies as Muslim. This is the quadruple stigma or the quadruple whammy. And unsurprisingly, outcomes in this group are terrible. If you are a Black person in the UK, you are 4 times more likely to be detained under the Mental Health Act compared to those who are not Black. Once you are in mental health care services, you are 8 times more likely to be referred to prevent if you are a Muslim compared to if you are not a Muslim. So God help Black Muslim people with mental health problems in the UK. currently under mental health care services. We talk about cultural competence. I prefer the term cultural humility. I think what we need to talk about is structural competence. Let's talk about some of the structural factors that contribute to mental health problems in minority ethnic and faith groups in the UK. Poverty, unemployment, discrimination, the PREVENT program, for example. Here we have Trisha Goddard, and she is a British television personality and mental health advocate. And she described, well, she experienced both depression and cancer and described both experiences as horrible. But with breast cancer, people ran towards her with open arms and hugged her. With depression, people ran away. When she was diagnosed with breast cancer, she was inundated with get well soon cards. But the moment news leaked out that she was admitted onto a psychiatric ward following a nervous breakdown, not a peep, and certainly no cards. Stigma. Stigma is a formidable barrier to mental health care. And consequently, many people with mental health problems continue to suffer in silence despite the availability of effective treatment. I repeat, many people with mental health problems continue to suffer in silence despite the availability of effective treatment. And if that was physical health, there would be outrage. But instead, we have a deafening silence. This is Dr. Daksha Emson. She was a brilliant psychiatrist and a loving wife and mother with bipolar affective disorder, who tragically killed herself and her 3-month-old baby daughter, Freya, during a psychotic episode, doused her with kerosene and set her alight. An independent inquiry into their deaths concluded that they were victims of stigma in the National Health Service. If there's going to be one take-home message, let it be this one, that stigma is killing people. Stigma is killing people. So stigma is an umbrella term that can be deconstructed into 3 components: problems of knowledge, ignorance, problems of attitudes, prejudice, and problems of behavior, discrimination. Now, this is necessary when we want to operationalize stigma, when we want to evaluate anti-stigma campaigns, because there are validated psychometric stigma scales in each of those domains. How do we challenge stigma? There are 3 broad approaches: through protest, through education, and through social contact. And a systematic review and meta-analysis on challenging the public stigma of mental illness revealed that social contact with someone who has lived experience of a mental health condition was the most effective way of reducing mental health related stigma in adults. Why? Why? Because when you meet us, you discover that we are law-abiding, peace-loving, community-serving citizens, and that we have hopes and fears and dreams and strengths and vulnerabilities like everyone else. You discover that we are human too. Now, the authors of the study conclude that people with lived experience must operate at the vanguard of anti-stigma campaigns because we have the power to reduce mental health related stigma. So I was inspired by my fellow survivors to pioneer the wounded healer, which has been described as an innovative method of teaching, an innovative anti-stigma program that blends the performing arts and storytelling with psychiatry. And the wounded healer traces my recovery journey from impoverished and hopeless and suicidal service user from a BAME background to empowered mental health advocate and doctor of the year. And the argument we make is, how can you educate an audience if you can't engage them? So I literally reenact scenes from famous films, I recite poetry to entertain and engage audiences, and then once engaged, we educate them and we equip them with knowledge and facts to debunk the many myths about people who have mental health problems, reduce stigma, and encourage care seeking. So it's delivered by an expert by personal and professional experience. We coined this mnemonic EPPE. So also known as a wounded healer, a psychiatrist who has lived experience rather of a mental health condition. So I've been fortunate to deliver it to over 100,000 people in 20 countries in 5 continents worldwide. And this is some of the feedback. You know, I have encountered resistance. Let there be no ambiguity. We've made progress, but stigma is still rampant in the world. And I delivered a grand round in an Ivy League university, and the cameraman's assistant, who had no background in mental health, just gravitated towards me and embraced me. And he said, thank you. Thank you for making me feel normal. Then I had a meeting with the head of the Department of Psychiatry, a professor of psychiatry. And I entered his office, and when I opened my mouth, his face contorts as if I'm about to contaminate him with some ghastly disease. He is disgusted by me. He can't wait until I leave that room. So if I'm in a crisis situation, am I going to go to this expert in mental health, this professor of psychiatry who likes to isolate himself in the lofty confines of an ivory tower? Or am I going to go to this cameraman's assistant who has no background in mental health? Who is going to dignify me? Who is going to provide me with that sanctuary that I need when I'm at my most vulnerable? This professor of psychiatry? So getting feedback, like, and you know how painful that is, by the way. I wrote an article about it, the wounded psychiatrist for the Psychiatric Times. I still don't forget. Yeah, it's very painful, to the extent that it actually sometimes I feel deterred to continue with my mission. But then when you get feedback like this, it inspires me to continue. And this is the global footprint of the wounded healer. I took 3 years out of my training to scale it up and deliver it face to face. None of this YouTube. I mean, don't get me wrong, obviously YouTube is powerful, and I would highly recommend it to scale up anti-stigma interventions, because we know that virtual contact is almost as effective as face-to-face contact. But I'm sure you'll agree that nothing can replace face-to-face contact. But it's challenging, because initially when I pioneered the wounded healer, there's actually stigma attached to conducting research on stigma. So I went to one of these prestigious universities, and they asked me, what do you want to do your research on? And I told them challenging mental health related stigma. Unsurprisingly, all white panel, middle upper class. And they laughed at me. And they said, isn't that soft? So I had to do this initially out of my own pocket, no funding. But now, by the grace of God, alhamdulillah, the invitations won't stop pouring in, alhamdulillah. So we have an opportunity now to raise awareness. What can we do about mental health stigma at the workplace and beyond? So, for example, universities as well. So 3 broad approaches to mental health. So we can have a proactive approach. So prevention is better than cure. Prevention is better than intervention. Developing mental health resilience, for example. A healthy body is a healthy mind. However, it doesn't matter how many Zumba classes you attend, unless you address some of the structural factors. For example, if there's a workforce shortage, then people will continue to experience mental health problems. There's the reactive approach. So let's say you're a student and you develop psychological problems, then you will refer to a counselor on campus. So that's the reactive approach.